Hello, and welcome to this presentation about compliments, complaints, claims, and comments, an alternative model for scoring patient satisfaction. My name is Kelly, and myself and my co-authors work in two wonderful Irish hospitals. One is a major academic teaching centre in Dublin with an ED hosting over 50,000 visits per year, and the other is a smaller but affiliated centre in a coastal community just outside of town, hosting about a third of that. Our group started thinking about this issue a little more critically when we read this article in an American magazine, which talked about what seemed like a very well-resourced program to measure patient satisfaction, the results of which are actually being used in the allocation of resources. Key words in this system being consumer and provider. The health service in our country has a relatively new program called National Standards for Safer, Better Healthcare, placing at its center the service user and having as its first theme person-centered care and support. We didn't know who came up with this concept of person-centered care, but we guessed these guys had something to do with it. The WHO's explanation of person-centered care is that it is rooted in universally held values, the principles of which are enshrined in international law, such as human rights, non-discrimination, participation, and equality. The rationale which brought these lovely words to the fore was twofold. Firstly, population health patterns were changing. The burden of disease was shifting from infectious diseases to chronic diseases, where there was a need for people to have continuing contact with multiple practitioners. On the other hand, population patterns themselves were changing. There were higher levels of education, increased availability of information, greater access to goods and services, and these were all altering community expectations of healthcare. So in what really is a new context, they identify not one but three main issues. The first is patient satisfaction. This was because studies across many countries were finding that over half of their populations were dissatisfied with their current health systems. The second was that of patient safety, because as we're learning, iatrogenic health problems can exceed 25% in some areas. And the third was one I hadn't heard of before. They call it responsiveness of care. This is what they refer to as people's non-medical expectations: dignity, confidentiality, autonomy, and access. Sticking with the first issue, though, we wondered how can we measure patient satisfaction in Ireland? Of note, Ireland is a publicly funded system, it is financially quite restrained, and it is definitely overcrowded. We looked at what existing resources might help us. Hospitals in our country generate quarterly reports of complaints and compliments to the health service executive. Quite separately, they report all claims to the state claims agency. This is the government agency that pays them. And separately again, some hospitals, our hospital, leaves comment cards all over the hospital with standard and free-form questions, which are also compiled into quarterly reports. This system was started by nurses because nurses care about this sort of thing. It's important to note that these four potential data sources would largely be considered unsolicited feedback. There are pros and cons to this sort of data. On the one hand, you're getting a strong feeling one way or another. The subject matter is on their terms. It's not contrived. It's what matters to them. The timing is on their terms. We're not sure how representative a sample it is, but it's definitely free. On the other hand, you could argue that we're only getting the squeaky wheels, that the subject matter is on their terms, not necessarily the parameters that we are interested in, that the timing is on their terms, and again, we're not sure how representative a sample it is. However, this is perhaps not an unreasonable starting point for a public free service in a democracy where not everybody votes either. So this is how we did it. We wanted to generate an easy-to-interpret score from 0 to 100, where 50 was good. We started with the complaints database from 2014, in which complaints are broken down into 16 categories, of which 10 are really relevant to our hospital. Others have to do with childcare and nursing homes. We then pulled copies of all the compliments from the same time period, and we classified them into the same 10 categories. We did the same for the claims, but we did this over a 10-year period rather than a 1-year period, as they're fewer, but they do have a very significant impact. We then also reclassified the comment cards into the same 10 categories, and these were on a scale of poor, fair, good, very good, and excellent, where again, good was the midpoint. These are our results. Interestingly, while this wasn't the case for the whole hospital, the emergency department had equal numbers of compliments and complaints. Quite strikingly, the compliments and complaints, where people could write about anything they choose, both fell within categories that matched quite strikingly into those non-medical themes we described earlier, the issues of responsiveness. However, the compliments weighted more heavily in the area of safe and effective care, and the complaints weighed more heavily in the area of communication. By contrast, 80% of the claims arose from issues around clinical judgment. This is quite consistent with claims data we've seen elsewhere in this conference. So we took our complement score, subtracted our complaints and claims, and then added this to our comment card score for a total score, which in our case was 55. We also looked at the clinical patterns behind these numbers. The emergency department accounts for 37% of all hospital visits, although we had 54% of all the compliments and 33% of all the complaints, and the emergency department was implicated in 63% of claims. The compliments came largely from the ill, 86%, and when they came from injuries, they were mostly bigger injuries, such as hip fractures. By contrast, only 43% of complaints came from illnesses, and 2/3 of those were surgical and not medical cases. Claims were very heavily weighted, 80% from injuries. This information can be very useful when it comes to risk management strategy. For example, one of our hospitals runs a separate injuries unit, which during peak times is always staffed by a senior doctor, and throughput goals are 2 hours or less. It's important to note a few things about this method. While complaints are meticulously logged, compliments are often underreported and they're not categorized. Both compliments and complaints lack a medical counsel component. So if a complaint is made about a particular doctor rather than the hospital, this goes directly to the medical counsel. Also, there are inconsistencies in our group. In the smaller hospital, all of these data sets are managed by one wonderful risk management officer. But in the larger, it's spread across several offices, and in fact, we've not yet been able to successfully use the model in the larger hospital. Also, as we're increasingly aware, a lot of unsolicited feedback about hospitals is fed to the internet and social media. This also has important implications for risk management, and we would do well to be more aware of this body of information. And this model still lacks a statistically representative solicited sample, so a survey. In conclusion, this is possibly not an unreasonable approach to patient satisfaction, given a publicly funded system, especially if tweaks on existing data sets could be made. People speak of dashboards. Rather than an odometer where we try to go farther, faster, which has a different role in a healthcare system like America, we were trying to perhaps find a barometer which measures pressure rather than speed. And on a scale of 0 to 100, where 50 is good, 55 is good. Also, it would still be interesting to compare this to an HCAHPS type survey system. But even if we did, it would still probably not be an accurate proxy for person-centered care. So we might look more closely at things like patient safety scores and quantifying responsiveness. Thank you.